So I was given the headline of TAVR complication surprise, and I'm not sure if it was that much of a surprise in retrospect, because obviously retrospect, hindsight, it's 2020. So our case is a 97-year-old gentleman with a past medical history of abdominal aortic aneurysm, status post-endovascular repair in 2015, complicated by a type 2 endoleak. Had severe mitral regurgitation, was treated with transcatheter mitral therapy with a mitral clip device in 2015. The post-operative echocardiogram, this is following a mitral clip placement. His LV systolic function is 55%. And there was a reduction in MR from 4+ to 2+. And at the time, aortic stenosis was moderate at best with a mean gradient of 20. There was a decline in functional capacity for the past 6 months with dyspnea and exertion with minimal activity, New York Heart Association class 3 symptoms. So the repeat echo in 2016 showed an EF of 50%, a mean gradient of 28, so mean gradient went up, a valve area of less than 1.8, and a dimensionless index of 0.21. I'll add here that I have not written it, but the stroke volume index was less than 35. So by definition, could be considered paradoxical low flow, low gradient severe AS. And had moderate tricuspid regurgitation with an RV systolic pressure of 63 estimated on echo based on the tricuspid regurgitation jet. So these are the images from the repeat echo in 2016. As you can see, mitral regurgitation, say moderate. There's a clip in place, and then there's moderate tricuspid regurgitation as well. So ECG showed normal sinus rhythm, baseline right bundle branch block, hemoglobin of 10.5, creatinine of 1.9. And the heart team decision was to proceed with transcatheter aortic valve replacement based on risk assessment from the Society of Thoracic Surgeons risk score, advanced stage frailty and renal impairment. This is his pre-procedure angiogram, so no evidence of obstructive coronary disease. And that's the CT scan. Okay, that's good, it's playing. So it's the CT scan to assess for femoral access. So just pay attention to when the femoral head is displayed right there. And then you could see the access on both sides. So fairly good access for a transfemoral case. And this shows the tortuosity of the aorta. It's a 3D reconstruction. Now the perimeter was 77. The sinuses are large, 34, 35. And my question to the panel is, what do you think should be the choice of valve and also the approach? I think we briefly went over the approach here, but what do you think?
I would say very tortuous aorta, put a S3 valve, easier to put on.
So a lot of calcification of those femoral arteries. I thought maybe towards the top of the left femoral head might be the best spot
and take a look,
access.
see if that plays again.
But it's not too bad, it's access.
Yeah, I'll just play the multiplanar reconstruction again.
I have a simple solution for that, because if they can do EVAR, you can do a TAVR. So that is, because you're more sophisticated and it's smaller size.
Here, the anterior, right here at the top of the femoral head, the anterior portion of the left femoral is okay.
Yeah, I think this cut down and sutured and all that. So you can just go above it. Whereas I think this is...
Okay.
Actually, so given the complication I'm going to talk about, we'll say maybe it was not a good idea to do a subclavian, but so we went in with the choice was core valve. This is just a run of the fluoroscopy for you to appreciate the degree of tortuosity.
Okay.
And
that's an evolute?
No, this is an Evolute. It's a resheathable Evolute, not the Pro, but Evolute R. It's a 29 Evolute R.
It doesn't look like you used a Lunderquist wire to help you get up either.
No, this is just a Safari wire.
Okay. But you're across and it looks, no trouble going up. It just tracked everything through, no resistance.
Yeah.
Watch the nose cone, make
Yeah,
sure it didn't
we-
separate from the capsule.
And most of our cases, we do sheathless, so we dilate with a 16, and then we take the 16 out, and then we go sheathless. And, under fluoroscopic guidance, it went all the way. It was tortuous, for sure, but then it went, and we assumed really good position, as you can see here. And at the time, we were actually at this position. Patient developed sudden hyperventilation, and there was a suspected. We thought this was an acute stroke at the table. So obviously, we had to stop what we were doing. We called anesthesia. The patient had to be intubated, and we got the valve. The valve was across, so we had to actually, just recapture the valve, pull everything out, and stabilize the patient first before thinking of doing anything else. And then we decided to switch to, as Dr. Kapadia mentioned earlier, S3, because we didn't want to deal with the tortuosity again, because it was painstaking to get to that point, and unfortunately the patient had a stroke. So our next valve was a Sapien 326, based on an area of 435 millimeters square. And this is the Sapien getting deployed. No issues in deploying the Sapien valve at all. And then the post-operative course, so the echo showed that the TAVR valve was well seated with trivial aortic insufficiency. There was no effusion. And then the CT of the brain vessels demonstrated that there was a basilar artery thrombus. And actually a mechanical thrombectomy was performed, but eventually the patient succumbed to the perioperative stroke. So we think maybe in retrospect we could have just gone up with the Sapien to begin with, to avoid all the manipulation at the level of tortuosity. Although the recent analysis from the Sentinel disproves that theory. It
Or you
disproves-
could use Sentinel too. That's another thing that you could use cerebral protection.
Yeah, but
Right.
How it went there is a question, but yeah, anything is possible. But the way the aorta was is very unlikely. It went like.
Like the guy hadn't gotten hypotensive, he would have done fine for you. It was going
Oh, sure.
It was doing fine.
Yeah.
You could go either way. You could have gone into some Flavian. You might not have had this. You went into some. I mean, who knows? These things.
Right.
Yeah.
97 years.
Right.
I mean, it's made it be 6 of one, half a dozen.
What could have happened from a subclavian approach too, though? Right.
Flavian approach
Yeah.
could happen from a carotid approach. I mean, looking like you had a pretty good position. You were doing great.
Yeah.
And then the guy had an acute event.
Mhm.
Which could have happened with anything.
Sure.
Well, that was great, Ankur. I mean, and I wouldn't, these things happen with every single case, right? So we've had strokes and I guess we're becoming more convinced that Dr. Kapadia is correct, that we should try to think about defaulting to some device that is going to provide cerebral protection. There's certainly a number that are in the works, but I actually don't think it was an issue of the Sapien versus the Evolute for getting
Yeah.
up and around. I think you probably would have still been maybe easier, but you still would have been navigating the same territory with the Sapien.
Yeah.
So that's good. All right, well, thank
Okay,
you.
thank you.
Yeah, thank you.